So we'll continue with diparacetamol, which is mainly used in combination with aspirin after ischemic stroke, transient ischemic attack. Mechanism of action: inhibition of phosphodiesterase. There is increase in the cyclic AMP level and decrease in the intracellular calcium levels. There is decrease in the cellular uptake of adenosine and inhibits thromboxane synthase. Now, therefore, the effects of adenosine are increased when you give diparacetamol. GP2B, glycoprotein 2B3A receptor antagonist. These are apixaban, eptifibatide, tirofibam. Hydralazine, this increases the cyclic GMP and causes smooth muscles to relax in the arterioles more than the veins. Indication: hypertension in pregnancy, severe hypertension, contraindications: SLE, ischemic heart disease, and cardiovascular diseases. Adverse effect: there will be tachycardia, palpitations, flushing, fluid retention, headache, drug induced lupus. Ivabradine, anti-anginal, decreases the heart rate, acts on the channels of in the SA node and decreases the cardiac pacemaker activity. Adverse effect: there will be visual effects in ivabradine. There will be luminous phenomena. This is asked. Visual effect in ivabradine is very often asked. A luminous phenomena is seen. There will be headache, bradycardia, and heart block. Loop diuretics: these will inhibit the sodium potassium chloride co-transporters in the thick ascending loop of Henle. This decreases the absorption of sodium. The loop diuretics work on apical membrane and must be filtered into tubules by glomerulus before they can have any effect. Therefore, patients with poor renal functions escalating dose to ensure escalate the dose to ensure sufficient dose concentration. Indication for loop diuretics: there will be heart failure, both acute, IV, and chronic. Resistant hypertension is the other indication. What are the adverse effects of loop diuretics? Hypertension, decrease in the sodium, decrease in potassium, and decrease in magnesium. So loop loses sodium, potassium, magnesium. It will cause hypochloremic alkalosis, ototoxicity, and calcium. So it will decrease everything. There will be renal impairment from dehydration, direct toxic effect, and increases the glycemia and gout. Thiazide diuretics: these on the other hand block the sodium chloride synthetic channel in the DCT and decrease the sodium reabsorption. There will be more sodium in the collective duct. It will cause hyponatremia, hypokalemia, but it will cause hypercalcemia, gout, and impaired glucose tolerance and impotence. Also, it will decrease the platelet. There will be a granulocytosis, photosensitivity, and pancreatitis. Adverse effect: dehydration, postural hypotension in the thiazide diuretics. Nicorandil is a vasodilator and it is used for the treatment of angina. It is a potassium channel activator and it will stimulate guanylyl cyclase, that is increase the cyclic GMP. Adverse effect: there will be headache, flushing, skin, mucosal, eye ulceration, GIT ulcer, increase anal ulceration anywhere in the GIT. So this is asked. Ulcers in the GIT are associated with nicorandil. Contraindication is left ventricular failure. Nicotinic acid, niacin. This is used in the treatment of hyperlipidemia to decrease the cholesterol and triglyceride concentration. It will also increase the high HDL levels, and adverse effects include flushing mediated by the prostaglandins, impaired glucose tolerance, and myositis. Nitrates, vasodilators. Mechanism of action: release of nitric oxide in the smooth muscle, activating the CGMP. This will decrease the intracellular calcium levels. In angina, they both dilate coronary arteries, decrease the venous resistance and venous return, and decrease the left ventricular work. Therefore, decrease the myocardial infarction MI demand. Side effect: hypothyroidism, there will be tachycardia, there will be headaches and flushing. Nitrate tolerance. The second dose of isosorbide mononitrate after 8 hours rather than after 12 hours to avoid nitrate tolerance. So uh, you have to adjust the dose. The second dose, the first dose, after the first dose, the second dose of mononitrate should be given after 8 hours in case the patient is having nitrate tolerance. Statins, this will inhibit the HMG-CoA reductase. This is a rate limiting enzyme. Inhibition of HMG-CoA reductase rate limiting enzyme in liver cholesterol synthesis. Adverse effects include myopathy, especially old female, decrease less BMI with less BMI, and multisystemic disorders. Most common lipophilic are simvastatin and atorvastatin, and lesser hydrophilic are rosuvastatin and pravastatin and fluvastatin. So, in case if the patient has got myopathy, if you're suspecting they might have myopathy, better to start with Rosuva or Prava or Flua rather than Atorva or simvastatin. Liver impairment, check LFTs at baseline, then 3 months and 12 months. Stop the treatment if the serum transaminase are 3 times the upper limit. If there is increased risk of intracranial hemorrhage, avoid status. Contraindication: macrolides, erythroclarithromycin, and pregnancy. These two are the contraindication for statin therapy. What are the indication of statins? Cardiovascular disease, stroke, transient ischemic attack, ischemic heart disease, PAD, peripheral arterial disease, 10 years CVS risk more than 10%. If the patient has got type 2 diabetes mellitus, Q risk 2. If type 1 diabetes more than 10 years and age more than 40 and nephropathy, then you will start with statins. 10 years diabetes, age more than 40 or nephropathy. Should be taken at night because majority cholesterol synthesis takes place at night. Atorvastatin 20 mg for primary prevention. Increase the dose